My name is Byrne. My assignment is to talk a bit about medications in heart failure, and I added a subtitle of what are the implications for Bar syndrome, because this is sometimes a separate category, really, of how to consider what medical therapies work and where we get these concepts from. You know, for full disclosure, some people thought the convention in Cleveland borrowed a bit from the WWF, the opening, but it really came from the AHA. So there are breakthroughs in heart failure. There are new medications being developed all the time. Some of them will have utility in Bar syndrome, and some may be best avoided. I'm going to stick to some very basic concepts so that you all understand where these medications act, how they may help and how they may not help. So here's the simplified version. You know, we have to consider where the blood's coming from the body into the right side of the heart, out to the lungs through the pulmonary artery. That's the blue blood, and then it's oxygenated in the lungs, comes back in these pulmonary veins to the left side of the heart, and then gets pumped out to the body. As Carolyn mentioned, you know, a lot of focus is on left ventricular function because that's what controls perfusion to all the organs and to the brain. When there's a limitation in left ventricular function, it affects growth, and then ultimately passively can influence the blood returning from the lungs, and that's the concept of congestive heart failure, because the lungs have extra emptying pressure and obtain some fluid that makes breathing more difficult. And really some of the early presentation of heart failure is really due to this fact, the diminished emptying of the left ventricle, and in turn the receiving chamber, the atrium, causes congestion in the lungs. But when there's a genetic cause of cardiomyopathy, the right heart and the left heart really are made up of the same stuff, and they're really, even though we often refer to those independently, they really work together, and they can never really be separated. So we may consider how drugs act on different compartments, but ultimately it all comes together right here. So this is a chest x-ray, which is often the first test that's done in a patient who has some breathing difficulty, or an incidental finding, actually, sometimes, that the heart is way bigger than it should be. For a growing child, their heart is about as big as their closed fist, and you can imagine if you put that on your chest, that's not going to be that big. That's more than half the size of the chest, and that is an indication there's a problem. And the other hallmark of this x-ray is the lungs are opacified by the extra fluid. So this is, when this is seen, it's often actually a very late finding, and in fact the echo is a much more sensitive way to assess heart function. This really is a better way to assess the partnership of the heart and the lungs and how they're working together, and you see that the large heart is causing congestion in the lungs. So that is usually the tip-off to look further. And the early presentation often is respiratory, particularly in the youngest children, because they have two main tasks: to eat and to grow. And when you're eating, you can't breathe. And when you're breathing, you can't be eating. So if you're spending a lot of time breathing, because there is a limitation of lung function from the fluid, growth is impaired because you stop eating as much. And this happens in older patients as well in terms of their breathlessness. So the breathing function is a key indicator of how the heart's working. Obviously, if you swallow a peanut, you're going to have trouble breathing. Or if you have asthma, you're going to have trouble breathing. Or blood clot in the lungs can be a problem. These other things are unusual. Pneumonia, or air entering the chest cavity and pneumothorax are rare, but what we're talking about is this problem in the middle here, this little heart sticking its tongue out, says, "I'm not happy," and that's pump failure. And that's usually what we're dealing with. So it can be more common to see symptoms that relate to the breathing issues that can lead to right heart problems, but breathing problems are not a hallmark of Barr syndrome from the standpoint of other diseases where there may be nighttime hypoventilation or primary lung diseases that cause the right heart to be in trouble, like a pulmonary hypertension, a primary abnormality of the arteries in the lungs. So we don't ever see isolated right-sided heart failure in patients with Barr syndrome. Left-sided problems are the issue in some ways, partly because the architecture of the left ventricles seems to be different. This so-called non-compaction or spongiform cardiomyopathy that is associated with Barr syndrome does lead to problems with perfusion out to the body and this pulmonary congestion I mentioned. So exercise intolerance is another hallmark of left heart dysfunction. So we do focus on that a lot, and that's where most of the medical therapies have been directed. So this is a bit complex, not meant for you to read every detail, but to say that there are really excellent guidelines that have been developed for the very large population of adult patients with heart failure. And even though in the pediatric world it's a much smaller population, we have learned from these algorithms or this recipe for understanding and preceding early stage patients at risk for heart failure. Sometimes those with structural heart disease without symptoms are very more at risk for heart failure, and then those that actually have developed heart failure or that where the heart failure can't be managed. And there's an approach to each one. Both the therapies and the goals of treatment are laid out in adult patients with chronic heart failure. And so we have learned both about safety of given medications from large populations of patients who have been in studies testing these therapeutic approaches. And the mainstay of therapies I'll describe is the point of this discussion was to talk about drugs. So I'll get to that. So this is common also in pediatric heart disease, and a good proportion of those, even with plumbing problems with structural heart disease, will develop forms of heart failure from either extra blood flow or structural problems that mean the contractile function of the heart is diminished because of the way it was built. This is, in fact, the heart failure is the most common indication for pediatric heart transplant, although we now know that there are some transplants that are done for very severe congenital structural abnormalities. So just as Carolyn pointed out, this is a problem when the output of the heart doesn't meet the demands. And certainly in the growing child, this is a constant challenge because the needs increase, especially in the early years in life. And that actually is really one of the best indicators of the heart's performance is whether growth demands are being met. And so that's why we're so careful about measuring weight gain and length in all the kids. So we have the ability, a huge ability, in fact, in most cases, to compensate for extra work. So when you have a demand of going up steps or growth, like in an early childhood, the demand can be met by reserve capacity in the heart and especially in the lungs. So the lungs are way overbuilt because they are designed to allow us to exercise. So maximal exercise tests, which were done in the past, and boys actually are best predictors of heart function, not lung function. In some ways, the combination of the heart function, lung function, and the skeletal muscle capabilities. But in the structural problems, there can be too much volume, too much blood recirculating. There can be problems that cause extra work on the heart by the strain of the arterial vasculature being compensating for low pumping ability, and then abnormal rhythms create a problem, and then primary problems that affect contractility, which would be relevant for Barr syndrome. So here's the basic principle of what the drugs attempt to do. a drug that actually improves contraction, increases cardiac output this way, and that results in changes in end diastolic volume. So the heart pumps what it gets. This is a basic principle of heart function. And if there's not enough blood coming in or it's not filling sufficiently, it can't empty that part out to supply it to the body. When a medication improves the function, the contractile function of the heart, this is the curve we want to follow, the dark line, and that's called an inotropic effect, so a positive inotropic effect. Some drugs negatively affect the filling of the heart, and these are negative inotropic effects. This means you get, for each increase in the pressure for filling, you don't get as much output as you would normally. And some drugs used to treat rhythm problems in particular, which is part of the complex of disease, have this effect. So you have to balance the one with another. So what are the main medical management strategies? One is to make the workload on the heart less. So this concept is called afterload reduction. Afterload is the work the heart has to do against the arterial vasculature to overcome the resistance of that vasculature. And the two most common pathways that are attacked are in the angiotensin system, which helps us control fluid volume and blood pressure. So ACE inhibitors, everyone's heard of that, and that has actually been the mainstay of therapy because these drugs are safe. They have little side effects in the sense of that they're well tolerated, and then they do seem to help in a preventative way and even acutely to reduce the workload on the heart and improve heart function. One of those that's given by infusion has a complex set of mechanisms. It's known as milrinone. Nitrate therapies are used usually acutely in the intensive care unit, and then a small peptide that's made in one side of the heart is responsive to pressures in the right side of the heart, can now be used in the intensive care unit by infusion to improve the heart function. The other side of the equation is if there's a diminished kidney function, it's possible to improve the elimination of water by diuretics. That also helps with lung mechanics, that the lungs can be congested. You'll see that this magical peptide works in a lot of different ways, but this is not for home therapy. Beta blockers can be useful and more commonly used in adult heart failure, but many combination therapies have beta blocker-like activities like carvedilol. We tried in the pediatric community to study carvedilol among all causes of heart failure in children, and the study, was very well done study by Bob Shaddy, who was at Utah at the time and now in Philadelphia, showed that actually carvedilol was not advantageous over conventional therapy, which was ACE inhibitors. But yet we still use it. So it has value for its beta blocking effect, but in terms of its activity related to heart failure, it's not clear that in all patients across the board it'd be helpful. And then there are other medications that can help with so-called remodeling. So this is the simple ABCs of how to remember what these drugs do. The alpha receptors in the vasculature constrict the vessels, and they're sometimes used to increase blood pressure in the case of acute heart failure and shock. The beta receptors cause dilation. And so there are ways to manipulate either sometimes with short-acting drugs, sometimes with long-acting drugs, but they ultimately can be used to reduce the workload on the heart. And then the mitochondria are key in all this because the heart is intensely dependent on ATP production and energy. We know that in Barr syndrome, some of these pathways are disrupted, and that means that some medications that force increased energy production can be a problem, and we have to be avoided. So one thing about mitochondrial function we know from studies on aging, and hopefully as we continue studies in Barr syndrome, the mitochondrial function is influenced by exercise. So that's not a drug, per se, but you have to say if it fits your busy schedule to exercise 1 hour a day or being passed out 24 hours a day. So you have to commit something to helping improve mitochondrial function through exercise, because there are some drugs that will influence the activity of oxygen, reactive oxygen species in the cell, but none can really repair the mitochondrial function like having tafazin or having more mitochondria to compensate. So that's the basic concepts behind drug therapy for heart failure, and I hope I kept it simple enough, and we'll go on to the next topic, and we're almost on time. Thank you.